It is my huge pleasure to introduce Dr. Mark Savill. He's an assistant professor at UC Davis in the Department of Psychiatry and Behavioral Sciences. He's a mental health services researcher who originally trained in London, England, before moving to California in 2015. His research has primarily focused on improving pathways to care and evaluating and refining the implementation of novel approaches to care for severe mental illness. He currently serves as the qualitative and fidelity lead of EpiCal, which we'll talk about in just a few moments, a learning healthcare network supporting early psychosis programs across California. I'm a proud card-carrying member of the group as well, so this is especially a special treat for me as well. Other recent projects that he leads are collaborations on early psychosis programs across all of the state, and they also include UC Office of the President Equity and Mental Health Evaluation, an R01 focused on refining digital pathways to care in early psychosis, and a formative evaluation of the Senate Bill 82 Mental Health Wellness Act, which provided grant funds to counties to improve access to and capacity for mental health crisis services. So thank you for all the work that you do and you continue to do. We're excited to hear more, and you can take it away.
Fabulous. Thank you so much, Dr. Stewart. It is an absolute pleasure to talk to you today. I'm so sorry I can't be there in person. I certainly planned to from the outset, but a few sort of competing deadlines meant that wasn't possible, but hopefully I can sort of be there again soon. It's, again, such a pleasure being here, not least being a UCSF alumni. So I was on the T32 program there under Dr. Rachel Lowy approximately 8 years ago. So it's lovely to be back and to see a few familiar faces in the chat. There we go. Before I get going, just to make clear, I have no disclosures I need to declare. And with regards to some of the topics for discussion that I'm going to be focusing on today, firstly, I'm going to be looking at what current best practice guidelines for early psychosis care are, how assessing fidelity can support the push towards best practice care delivery, and then finally, I'm really kind of going to get into the idea of what it really means to provide high quality early psychosis care. So I think that's really sort of where we get into the meat and sort of try and have a few sort of thought-provoking questions about where we go from here. So in these kind of things, I feel like it's always good to start at the beginning. So what is psychosis? And they typically include 3 clusters of symptoms. So one that focuses on sort of changes in perception, thinking, and communication. So that can include seeing things other people can't see, odd thoughts or beliefs that aren't shared by others, communication or speech that can be hard to follow. And this is a cluster that was historically been called positive symptoms. And it's something we're sort of beginning to shift away from based on input from our lived experience folks, but sort of the constellation of symptoms is the same. The second focuses on changes in expression and motivation. So challenges in motivation for daily activities, decreased verbal and bodily expressiveness. And again, this has historically been something called negative symptoms. And then the third cluster is around cognitive changes. So that can be impacts in areas such as attention, memory, and understanding of new information, and also social cognitive challenges. So things can impact the way social cues are interpreted. And before I get going, I think it's helpful just to kind of focus on some of the real kind of premises of the discussion I'm going to be doing today. And first and foremost is individuals with psychosis can experience meaningful recovery. And I'm very fortunate to be in a position with extended family members, friends, colleagues, collaborators, service users I work with. Sort of every day I see people with psychosis and with schizophrenia living meaningful, impactful, positive lives in a way that's important to them. And I think that's really important to kind of challenge some of the historical misconceptions we can see about psychosis and schizophrenia being this kind of inexorable decline towards homelessness and incarceration. Like that's just not something, I'm fortunate enough I'm in a position where that's just not something I see every day. Secondly, important premise is treatment is more effective when people receive appropriate services at the earliest stages of the illness. And I think that's been exemplified sort of most clearly by the RAISE study. so which was a randomized controlled trial done approximately 10 years ago now by Dr. John Kane and his group, that found treatment in early psychosis specialty care services, significant improvements in symptoms and quality of life was found amongst folks that had a duration of untreated illness of less than 74 weeks, whilst the individuals that had psychosis for longer than that cutoff point and longer than 74 weeks weren't finding improvements in outcomes. So really being appropriate care early. And then the third thing I'm going to mention is the gold standard of care for psychosis at this early stage of illness is something that we call coordinated specialty care. And different terms have been used. This is typically the word or the phrase that's used in the US, largely because it's being the one that's really pushed by the NMH. But other languages used in other countries being early intervention services, especially early psychosis care, sort of different terms that broadly mean the same thing. And when I say coordinated specialty care, this is the kind of configuration of service that I'm talking about. So very much a team-based, multidisciplinary approach to providing early psychosis services with a real commitment to recovery-oriented care. And the model is typically a team lead, experienced clinician, clear commitment to recovery-oriented approaches that kind of has overall management and oversight of the intervention. Case management, so all individuals receiving case management that can support individuals with problem solving, solution-focused approaches to practical problems, and coordinating all the different components of services that people may receive. Another key part is supported education and employment. And the idea is to have a dedicated professional that can really support individuals to kind of engage in what they see to be meaningful work or school. Idea being the earlier you get people back into school and in work, the better the outcomes we often see going forward. Psychotherapy is a huge component of coordinated specialty care, typically based on CBT principles, and can be emphasizing sort of resilience training, illness and wellness management, coping skills. Another key part is family education and support. So recognizing that supporting a loved one with psychosis can be a really stressful, difficult, challenging time. So supporting the whole family or the whole support network around the individual to address needs and understandings and misunderstandings that they may have, idea being that sort of having all the elements in place to really help that individual's recovery journey. And then sort of the final important component is pharmacotherapy. And that can usually, although not always, come in the form of antipsychotic medication, and alongside that, supporting individuals' physical health support. So supporting linkage to primary care, weight management, smoking cessation, all these kind of pieces that can be associated with reduced life expectancy amongst individuals with psychosis. So this is the model that was kind of really outlined by Dr. Bob Heinssen and his team at the NMH sort of around 10 years ago now. And there's been lots of different variations and modifications of this model. I'm not going to go into them too much because I think that's a talk in and of itself, but I will highlight the model that we sort of really are advocating for as EpiCal, and I'll talk about what EpiCal is a little bit later on. So as you should see, the model includes a lot of the core components that we saw in that table in the previous slide. So again, the importance of a team lead, a coordinated approach, case management, C support, pharmacotherapy and psychotherapy. A key part, however, that has really emerged in the last sort of 5 to 10 years or so and is getting increasing prominence, particularly in California, is the recognition of the key role that individuals with lived experience and family members can have in supporting people's recovery journeys in psychosis. So employing peer advocates, family, partners, really sort of helping a number of different ways, be it supporting engagement in care, helping to address stigma, helping support and facilitate culture change within services themselves, to really center the service user and the family at the approach in everything we do. And again, that's a big part of why this model has this framework, because the idea is that the service user and their family really are the central piece that everything else kind of revolves around. Okay, so I've mentioned EpiCal a couple of times now, so I'll start to explain a bit more about what this is. So this is something that's being led by Dr. Taryn Needham over here at UC Davis, and it is a learning healthcare network of approximately 45 programs across 40 counties across California. So a huge network across the state that probably represents, my guess would be, the largest learning healthcare network in early psychosis. So a huge collaboration between an enormous number of partners across this state. And within EpiCal, it's really an umbrella term for a number of different initiatives. So the largest one is our relationship from Department of Healthcare Services, Social Services, or DHCS, where they are supporting training and technical assistance to support the delivery of high quality early psychosis care. And essentially what happens is any county that is receiving the 10% set aside block grant dollars to support early psychosis care delivery, that then means you're eligible for EpiCal support. And EpiCal support can be a range of different services that I'll be talking about a little bit later. In addition to that, there's a smaller subset that are part of the EpiCal Learning Healthcare Network, or LHCN. And they are programs that have a bit more integration within our system. And in addition to receiving those training and technical assistance, they are also committed to harmonizing their data collection and submitting this data through an application we've built called Beehive. And then the idea is to create a dedicated data set of outcomes and surveys that have been identified and prioritized by our community partners to support innovation and evaluation of early psychosis care across the state. And then this data is then submitted to EpiNet, which is the nationwide sort of effort to collect a harmonized battery of data in early psychosis care. Okay, so that is EpiCal. And this is the network, the model that really kind of emphasizes what the training and technical assistance is. So it's a little complicated, so I'll just try to sort of break down some of it. So as part of the training and technical assistance, we have a series of teams of experts that focus on the different components of coordinated specialty care, of which one of them, Dr. Barbara Stewart, is involved in, which is the assessment piece. So supporting counties and programs to adequately be able to assess and diagnose and support individuals in identifying who may be appropriate for early psychosis services. Other teams include our cognitive behavioral therapy team, our medication management team, teams that focus on supporting group therapy and delivery. We have a dedicated family service, which is led by a family peer, SEAS leader, and also a team that supports outreach, so helping programs engage in their communities to support the referrals into their programs with a particular focus on addressing disparities that they may see in who's actually coming into their service and engaging in care. Other sort of service leads like this that have a more central role in really kind of the leadership and the philosophy of the training and technical assistance include our peer integration and lived experience team and our DEIA team. So they kind of have a dual role where, in addition to providing this real kind of specialized support to the programs to address these components of care, they also really kind of threads through everything that we do as an organization as well. So the idea being that we're really centering the voices of lived experience and really centering kind of addressing current and historical inequities we see in access and care when we're thinking about providing good quality early psychosis care. A key part of doing this is also the technical assistance component, and that comes in the form of county liaisons. So every program and county that is involved in the TTA, they meet with a very experienced provider who typically has been a team lead for a number of years beforehand, and they are meeting with the programs and with the county teams on usually a monthly basis to really support the programs in the counties where they're at in their stage development of providing early psychosis care. So that could be very small rural counties that are just in the earlier stages of thinking about standing up a program, and if so, what they might need to do to start thinking about that. At the other end of the spectrum, it could be supporting a program like the Filson Institute, who have been providing early psychosis care for over a decade now, and they're looking for specialist support in very key technical areas to tweak a very successful and established model. And then the last sort of big component of this training and technical assistance initiative is the outcomes teams. And that is supporting quality improvement and evaluation of the network as a whole, and then also this fidelity assessment team, which I lead and is going to be the bit that I'm going to be talking a bit more about going forwards. So, assessing fidelity to early psychosis best practice guidelines across EpiCal. First and foremost, what does fidelity assessment even mean? So, fidelity is the degree of implementation to an evidence-based best practice, and fidelity assessments provide a list of objective criteria by which a program or intervention is judged to adhere to a reference standard for the intervention. So basically what we're doing is we're going in, we have a very behaviorally anchored, structured list of components that have an evidence base to support early psychosis care, and we're collecting various pieces of data as part of their care delivery to see to what extent they are meeting all of these different areas. And this is important because higher fidelity to best practice guidelines has been associated with improved outcomes in many areas of healthcare. And I could have put down any one of a couple of dozen different studies and indications to kind of highlight this. These were literally the first ones that came up when I threw it in Google Scholar, so they're here. But what we find is higher adherence to a manualized intervention can support prenatal care, can support nurse-led interventions to reduce hospitalizations in nursing homes, and in more of a behavioral health context can also help things like assertive community treatment, so ACT models. In early psychosis care specifically, I think it's fair to say, a much earlier stage of development in really linking fidelity to improved outcomes. However, literally a few weeks ago, Dr. Abram Rosenblatt and his team, who led the mental health block around evaluation, just published a study that showed that higher fidelity scores predicted reduced symptoms and improved social functioning. So what they did was they evaluated approximately 40 programs across the US, and part of that evaluation included fidelity assessments. And what they found is the improvements over time in programs that had higher adherence to fidelity to the model had better outcomes. So it's that real kind of just beginning to see how fidelity can be important in early psychosis care. Another study that was done in the UK, it had a slightly unusual methodology. So I think there's some caution about reading too much into it. But what they did find was programs are more likely to be cost effective when they have at least medium fidelity to best practice guidelines in accordance with UK NICE guidelines relative to low fidelity. So in addition to us finding that higher fidelity programs can be more effective in outcomes, we're also some tentative evidence to suggest that they might be more cost effective to adopt this model too. Okay, so hopefully that's a good enough argument to suggest that fidelity assessments are important in early psychosis care. Now we can think about how to actually start assessing it. And when I first got the role as the fidelity lead of EpiCal, one thing that really struck me was just how many different fidelity assessment tools specific to coordinated specialty care are out there. So Pennsylvania developing their own, ESA, which is over in Washington, having one, On-Track system in New York having one, the team in Denmark that lead the OPUS study, that team have one. So there's lots of different fidelity assessment tools out there. So we had to have a little bit of a think about which one we would choose. Ultimately, we chose the FEPS-FS, which is the first episode psychosis services fidelity scale. And the rationale for that was, there's a few different reasons. So one was, importantly, it was been validated in multiple studies. So different teams have used this to support fidelity assessment. So it's not embedded just within one team. It has an international consensus, so it's been used in Canada, in the US, in Europe, and it's been something that's been a successful tool at assessing early psychosis care in different spaces, and has been recognized and established tool in this field. Critically for us, it was something that was found to work across different program models. And a key feature of early psychosis care in California is that the developing and programming has very much kind of followed a bottom-up approach. So the counties have really had a lot of autonomy in terms of developing their model and what their priorities and structure will be to support early psychosis care. And that's very different, for example, to On Track and ESA and others, where there's an established model, and then there is this oversight body that supports programs to adhere to that particular model. So we needed something that was robust enough to account for that variability, and there are studies out there that show that this tool can do that. So that was a big part for us. And then the last thing is, which kind of saved my air miles and my carbon footprint as much as anything else, is that it's been validated as a remote assessment. So as I mentioned, we're literally working from the northernest county right down to Imperial and on the border. So if I don't want to be in a plane every week and a half going to do these assessments, it really needs to be something we can do remotely. And through the mental health block grant study, it has been validated as a remote assessment tool. So this was the tool we selected. However, to use it, we recognized that a series of modifications are going to need to be done to really facilitate this in California. And one key thing is, like many fidelity assessments, it relies a lot on health record data that you can pull from people's electronic medical records, which is great for established programs that have been serving individuals for a while. It doesn't really work well for very small or very new programs that perhaps don't have enough service users in their system to give us that kind of data, or haven't been in care long enough to give us information, for example, around how they conduct annual assessments or the volume of care someone may receive over a year. So collaborating with Dr. Don Addington, who wrote the FEPS, he was very accommodating in working with us and thinking about ways we can adapt the FEPS so it can work for smaller new programs. And the idea is that that work will hopefully be published next year and can really help these kind of smaller programs, newer programs, sort of start from the very beginning, thinking about best practice guidelines and what they're doing and assessing their fidelity to that so that they can really start on the right footing. Another key thing for California, which is, again, a unique feature relative to a lot of states and programs out there, is approximately 90% of our early psychosis programs also serve individuals with clinical high risk in addition to full psychosis. And clinical high risk is when individuals are experiencing sort of subthreshold attenuated symptoms where they may not experience symptoms that are consistent with full psychosis, but can still have a lot of accompanying distress, functional impairment, and can be have outcomes broadly equivalent with a lot of mental health concerns such as depression and anxiety. So critically for clinical high risk, it can be a predictor of later conversion to full psychosis. So it's not a necessary link. It's not well, what I'm trying to say is, when the majority of people that are experiencing clinical high risk will not necessarily develop a full psychotic disorder, but the transmission rates are much higher in this population. So there's multiple reasons why there is an increasing focus on supporting individuals with the clinical high risk syndrome to hopefully avert transition to full psychosis and also address some of the impairments and distress that someone may have experiencing those symptoms. As I say, today there doesn't really exist a fidelity tool to assess clinical high risk care. So again, in collaboration with Dr. Addington, we developed something called the CHIRPS FS, which is something which is just coming out in psychiatric services, I think this month. So it's again, ways in which we can address assessing fidelity in a meaningful way that fits our state. Okay, so I'm not going to go too much into this. These are the items of the FEPS FS. So there are 36 items in total, and they look at various areas such as team form and function, delivery of pharmacotherapy and psychotherapy, eligibility and assessment sort of protocols, all these kind of different pieces. And there's, again, very standard structured ways of assessing the degree to which a program has met that. So this is how we assessed all of the programs. Okay, and then the last thing I'll say is there are 36 items for the FEPS FS, 33 items for the CHIRPS. So there's a lot of overlap between the two, but there are some components of care that are unique to each diagnosis. So that being the case, there's slightly different configuration that comprises of each. For every item we assess, they're rated on a 5-point behaviorally anchored scale, where 4 or 5 is considered to be adequate fidelity to the model, whilst 1 and 3 will often identify a potential area for growth, where tweaking practices may help programs get close towards what we understand to be best practice. So 33 items for the chirps, 36 items for the FEPs. That necessarily means then that the FEPs can be scored between 36 to 180, and the chirps can be scored from 33 to 165. Okay, and these are the assessments across EpiCal that we have done to date. So we have completed 28 FEPS assessments, 22 chirps assessments. In both cases, around 2/3-ish, we've been able to do standard assessments. So they've had enough service users in their program for a long enough amount of time to do a full assessment. But between 30 to 40%, we haven't been able to get that amount of data, so we've done formative assessments. So that really just highlights why it was so important for us to kind of standardize some of these changes that we made. Excitingly, the idea for this project is to do repeat assessments every 18 to 24 months. And we're now just getting to a stage where we're starting to do these follow-up assessments. So to date, we've done 4 FEPs and 4 CHIRPS assessments. And we have, I think, probably 6 or 7 ongoing follow-up assessments. So we'll have a lot more data in this area very soon. With regards to how programs are scoring across California, the mean FEPS score was 3.8. So it's just below this 4 level, which was being used by Don and other teams to indicate sort of a program that's consistent with high practice and good sort of evidence-based practice. And then with the CHIRPS score, it was slightly higher, so 4.03. And then with regards to the proportion of items that our programs are scoring at good high fidelity, so in FEPS, it's 58.6% of the items scored, meeting that 4 to 5 criterion. And then again, a little bit higher in the CHIRPS, where it's 62.4%. So almost 2/3 of all of the items at a mean level, our programs are scoring high fidelity. Okay, so that's kind of how we've been doing the assessments across the programs. And now I really want to talk a bit more about how doing this can really support the shift towards high quality early psychosis care. And I think this is really where we start to get to the meat of the presentation. So an important part of what we do is every single time we conduct a fidelity assessment, the programs in the counties receive a feedback report that looks pretty much exactly like this. So this is a de-identified one. But what it does includes a wealth of information for programs to support quality improvement activities. So within these reports, typically it includes summary information, so their total scores, average scores, number of items at good to high fidelity, which is, I think, a helpful kind of headline figure, but it's really when you get into the meat, I think it's where it can provide sort of real concrete, practical guidelines to support quality improvement. So beyond this kind of headline sort of mean scores, we're providing quite detailed information about sort of recognizing achievements and strengths. And I think an important thing to recognize is across California, so with all of the programs we've served, there's genuinely amazing work happening out there, really innovative approaches from some very experienced, hardworking, remarkable service users. And I think it's really important to champion and recognize sort of the fantastic work that's happening out there. So one of the first things we always do is really sort of celebrate and recognize the work that programs and providers are doing. And then the second areas can be looking at potential areas for growth. And that will be areas where perhaps people have scored lower on that 1 to 5 rate, and then providing real sort of hopefully simple, concrete steps that they may be able to increase those scores. And in this example, we looked at engagement and outreach, which is something that was a common area where programs were scoring a bit lower. So for this item in particular, what we do is to score a 5, programs would need to be conducting outreach and engagement. So meeting with schools, law enforcement departments, primary care, community mental health teams, at least monthly, explaining sort of what early psychosis is, who they are, how to facilitate referrals into their program. And the idea is to support a greater flow of referrals into their program and hopefully referrals in earlier, which we know can improve outcomes. So for example, in this one, a program scored 1 out of 5, where I think they conducted 5 of these outreach and engagement visits in the last year. We were suggesting if they do over 12, that then shifts from a 1 to a 5. So a simple way to really sort of tweak what they're doing to meet better guidelines. So meet kind of best practice guidelines. And then alongside these kind of bigger kind of areas for growth, we then provide item level information across the whole report. And again, that's what we have at the bottom here. This one looking at, for example, the number of people who have a hospitalization prior to be admitted to the program. And the hope is the lower that number, the better, because it means the programs are more successfully engaging with individuals earlier in the course of their illness. So in this one, approximately half of individuals that were receiving care in this program had a hospitalization prior to starting. To score higher, for example, 40% of individuals, so reducing that down by 10% would then increase that from a 3 to 4 where they're more meeting best practice guidelines. Okay, so a lot of information we're collecting at the moment is coming in the form of feedback reports. Going forward, the idea is to be developing dashboards. So my colleague, Brianna Savill has been working on this a huge amount in the last sort of year or so, and we're getting very close to a point where we can start pushing this. So again, this is a mock data, but we have the real data we can plug in. And the idea is to be able to provide dashboards to synthesize all of this information in a very sort of easy, readily accessible space, rather than these kind of long printed reports. So in these reports, we're talking about things like providing all of the FEP scores, creating sort of figures where we can compare current to previous scores. Now we're doing them over time. Allowing benchmarking, so comparing to statewide average, sort of identifying areas where programs may be doing particularly well relative to the state versus areas where they're struggling. And then information for the liaison staff, so these point people when they're meeting programs, that they have all this information in the same place that can really aid that conversation. So that's kind of where we're going forward, sort of really trying to digitize and automate what we're doing to provide sort of really meaningful information to support quality improvement activities. And as I mentioned, the assessments over time is a huge part for us for a number of reasons. So one, it will be to evaluate the impact of training and technical assistance support. We would hope to be seeing improvements over time. Another area is it can be very helpful for programs to evaluate themselves the efforts that they've been doing to support areas that they may have identified as key areas for improvement themselves. So a good example might be in the first assessment, only doing 5 outreach and engagement appointments in the past year, which would have scored them a 1. That's scored. They commit to trying to do more in the follow-up assessment. If they're doing more, then this will represent the change. So it's a concrete way to be able to demonstrate how programs are evolving their practice over time in a way that meets best practice guidelines. And again, very early, we've only done 4 follow-up assessments, but early days are really encouraging. And what we're seeing is programs scoring higher in both the FEPs and the CHIRPs at their second time point relative to their first. So again, very early days, and we'll hopefully even the next few months see if this is a much more consistent trend. But in the first episode psychosis scale, so the FEP scale, what we saw is the 3 programs that we assessed, scoring a 3.56 at T1. We came back approximately 24 months later, and the average now is 4.04. So a notable shift towards best practice guidelines. In the CHIRPs, this may be an artifact of a ceiling effect where we see a smaller improvement because they started at a higher base. So they were already at 3.9, but despite that, we're still seeing an improvement over time. So going up from 3.9 to 4.1. And obviously we can only speculate as to why these improvements are happening. Part of it may be a natural evolution towards best practice guidelines that the programs will do over time anyway, as sort of programs get more embedded and they're able to tweak what they're able to do. Part of it might be the provision of the training and technical assistance. So having all of these different training pieces and support that our initiative is providing, helping people transition towards sort of higher practice care. Another feature may actually just be the regular assessments of fidelity. And there's been evidence in other areas of healthcare where repeated fidelity assessments in and of themselves can support evolutions of programs towards best practice care guidelines. So it's likely to be probably a mix of those three things that's really leading to this trend towards improving care over time. Okay, and then another thing where we really want to start thinking more about the learning healthcare network approach is how this data can support that. So 7, 8 years ago now, when Tara, Dr. Rachel Lowy, and I were sort of sitting really thinking about what this could be at the very early stages of this project, sort of a huge motivating factor for us was recognizing that there is amazing, incredible work happening across the state, but it's happening in a very siloed fashion. So all of these individual programs doing their individual things in their own individual way, and then not being that much communication between programs and sort of collaborative learning from each other. And a key thing for us was by creating this learning healthcare network, the idea is that we can learn from other programs, sort of identifying what may be working particularly well in one program, understanding why it's working so well, then hopefully disseminating that across the network. And the idea being like a rising tide lifting all boats. And fidelity data can help with that. And what it can do is we can identify areas where programs are performing significantly better than the statewide average, which can then lead to us engaging with that program, understanding what they're doing and why they're doing it that way and how it's leading to better outcomes. And a really good example of this was one we had about 6 months ago with Ventura County. So they have a program over there called VC Pop. Something that we found across the whole state is that programs are really struggling to get a sufficient number of individuals in relative to the prevalence of early psychosis we would expect in the counties. So pretty much every program was scoring a 1, so only serving a very small proportion of the prevalence of psychosis in their space, in their catchment area. The notable exception was Ventura County, where I think they were serving something like about 50-odd%, relatively small county with a relatively small catchment area, but they had 150 individuals in their program, which was an enormous number compared to all the others. So this really kind of lit a light bulb in our head. We went to kind of sort of speak with their team lead, understand what they're doing, and from speaking with them, sort of two real kind of things that made them stand out was, number one, the huge amount of work that they were doing in engaging in the Latino community, huge amounts of work sort of developing these links with the Latino community, using a lot of caseworkers and case managers to really sort of embed themselves in community services, really understand the needs of the community, and really sort of develop a trust and link with members from that community, and that leading to a lot more referrals coming in from the Latino community relative to other counties that we look at. And a second one was having a very low barrier to engagement in care. So their program almost sort of doubled up as a crisis service program. So anyone that was sort of experiencing a mental health crisis could come into this program, receive immediate services, and then individuals that may be appropriate for early psychosis would then stay. So this very low barrier to engagement, and then this huge amount of outreach engagement work from their perspective had led to this huge number and increase in numbers. And I think that was something that was really eye-opening to us. And when we did our statewide learning collaborative meeting, so we had a meeting from all the leads across the state, we had them talk about what they're doing with the hope that other programs can learn from this and perhaps adopt similar practices, with the hope of boosting some of the engagement in historically marginalized communities and increasing the amount of referrals that are coming in. So again, this very simple assessment of what they're doing leading to something which could hopefully did identify areas where novel things are happening, which can then hopefully then translate for us to adopting those kind of practices on a more statewide level. And talking about the data that we see across the state, this is sort of getting a bit more granular now. So these are all 39 items that we have across the FEPs and the CHIRPs. And in this figure, when it is yellow, that is the proportion of programs that are meeting good to high fidelity. And when it is blue, it is the proportion of programs that are not meeting good to high fidelity. And what we can see is there's a huge variety in the degree to which programs are meeting these sort of good practice guidelines across the 39 items of the FEPs and the CHIRPs. So some areas, such as, for example, For the first one is looking at the team leader role. So firstly, if they have a team leader, experienced clinician that's providing administrative and clinical supervision and also direct care, almost all of them are doing that. So we're seeing a very large gold bar there. So an area where it's obviously we really are struggling is the age range served. And there's a number of historical reasons behind that. So pretty much every program we spoke to had an upper age limit of 25 to 30 years old. And this is increasingly finding us out of step with the international community, where, for example, the UK are now mandating serving clients up to the age of 65. And the real reason they are doing that is because we see an incidence spike amongst females, both postpartum and postmenopausal stages. So, well, that allied with the fact that females typically have a later onset of psychosis than males do. So what the perspective from the UK government was, by having these very kind of low upper age limits, what we're doing is we are disproportionately excluding females from early psychosis care, which can then perpetuate inequities in care access. So I'm not sure if we are there as a state yet to really start thinking about a broader continuum of care in early psychosis. But it's certainly something that when we can capture that data, is something we can feed back to the state level to explain kind of where we're currently at and potentially how we are out of step with the international community and how it's increasingly thinking about what early psychosis is. Additionally, it can find areas where I think it's fair to say we as a state are doing really well. And I think one of these is item 27 that looks at the amount of CBT that's being delivered across the programs. So what this is measuring is the proportion of programs that proportion of service users that are receiving at least 10 sessions of CBT in the first year. And so 83% of our programs are serving a high proportion of their programs are providing a lot of CBT. And that compares really well to early psychosis networks internationally. So for example, the ones in Europe and in Canada, it's been an awful lot lower. And this has been a real challenge for community programs to be able to provide. Linked to this, I think it's also important to mention in the RACE study, their psychotherapy was actually IRT rather than CBT. And one of the concerns around that was the challenge of delivering CBT in a community model effectively. So I think this is kind of, it's encouraging data to show that we can do this and we can implement this fairly extensively across California. That said, I think it does bring up a broader conversation where it shows that we have CBT specialists and we are providing CBT, but it also kind of highlights the limits of where fidelity assessment is, where we can't really dig into how effective or the degree of competency that's actually CBT is being delivered. So we know it's being delivered, but we don't know if it's really high fidelity to the actual CBT model itself, whether it's addressing service user priorities, whether it is sort of high quality care that we would hope to be seeing in this. And I think this sort of highlights some of the limitations that we can do in fidelity assessment on this kind of broader level. And this will be something I'll be tapping into a little bit more in a few minutes. And then the final thing I wanted to talk about is how fidelity assessments can really support the learning healthcare approach in action. And sort of a key feature of learning healthcare networks is firstly the systematic collection of data as part of routine care. And that data then identifies areas for improvement. Having identified these areas, you innovate and you design interventions sort of to address these areas that you find in the data. You disseminate them across the network, and then you can evaluate the outcome of that innovation. And I think it's fair to say we're still at the very early stages of doing this across California and EpiCal, but we're beginning to get to this stage, and I think already it's beginning to look quite exciting what we can do. And I think one of the clearest examples that we've done this is in the pharmacotherapy space. So we were collaborating with our medication management team, and I think something that really shocked our prescribers and our medication management team was just the volume of individuals with clinical high risk that were being prescribed antipsychotics, and the prevalence of polypharmacy. So people receiving multiple antipsychotics when they have an FEP. So what we found is at least 9 of 15 programs providing antipsychotics to at least 20% of CHRP individuals assessed. And again, that's very contrary to current best practice guidelines. It's been found not to reduce the rate of transition to full psychosis and can have a number of quite worrying side effects. So it's really something that's not been consistent with the current model. Another thing is there's been very much a shift away from the idea of antipsychotic polypharmacy, but we were seeing it in 20% of the individuals that we assessed. So this was a big concern, I think, to our medication management team, and they led them to completely revise the types of trainings that are being provided to prescribers. So we have an online platform which includes a lot of our trainings to the programs on Cornerstone, and they tweaked and modified a number of their trainings to really kind of emphasize what best practice guidelines are here and provide guidance around how to adopt alternative approaches. So this is using the data, seeing high antipsychotic polypharmacy and antipsychotic use in clinical high risk care, that then in innovating and informing how we provide care. And then the hope is in later assessments that we're doing now, we'll be able to assess to see if we see reductions in polypharmacy and antipsychotic use in clinical high risk as a consequence of making these changes. So again, this sort of learning healthcare network in action where using the data to identify areas for innovation, and then that same data can then evaluate the care that we're providing. Okay, so hopefully I've been able to provide a number of ways in which fidelity assessments can really support improvements in quality care in early psychosis. Now I really want to think about what it actually means to provide high quality care. So as I mentioned at the very beginning, there was a study done in England that found that programs that had at least medium fidelity to best practice guidelines were more likely to be cost effective relative to the low fidelity group. What I intentionally didn't include was the fact that the high fidelity group had the least likelihood of cost effectiveness. And the argument is that once we get past that kind of moderate level of fidelity, higher fidelity costs a lot more, but we're not really seeing changes in outcomes. So that then, I think, leads to a somewhat thought-provoking question is, does quality actually matter? Do we need to just get the essential components in place, get us to kind of medium fidelity, and then not bother going beyond that because all it's doing is costing more and not really resulting in better outcomes afterwards? And obviously, as someone that works in this space, I wrestle with this a little bit. And I think ultimately, the answer is no. And a big part of that is this particular paper that was done by Bennett and Rosenhack in 2021. And what they did was they looked at the race study and they looked at the outcomes, but stratified it by socioeconomic status. So, and what they found, which is hopefully fairly clear from this, so individuals in the highest quartile, so typically had family members in prestigious higher paying jobs, and they used a composite index which said that used race and ethnicity, so people that primarily identified as white, they were seeing the largest impact in outcomes, improvements in symptoms, in depression, in quality of life. If we look at the lowest quartile, what we're seeing is actually reductions in quality of life, increases in symptoms. So the absolute opposite direction of where we would want to go. So what we're finding is the impact of coordinated specialty care is not equal, and it is disproportionately serving individuals from the highest socioeconomic status. And I think that really kind of lends the question of, well, what is this model and what do we need to think about in terms of supporting it in a way that can address the needs of everybody? And I've talked a lot about fidelity at the moment, which is a behaviorally anchored assessment of the presence or absence of evidence-based components of care. And the argument is, do we need to start thinking beyond that in a way that can hopefully support more equitable outcomes of receiving this kind of care? And moving beyond fidelity, do we need to start thinking about competency? So the degree to which components of care are actually consistent with how they're meant to be delivered. So rather than just, are you delivering CBT? The question is, are you delivering CBT well? And hopefully thinking about that can iron out some of the issues. But to be honest, I'm not even sure if that goes far enough. And what we really need to start thinking about is quality, and really thinking about the degree to which programs can deliver what people want and need to support their recovery and wellness journeys. So that's kind of what I think we as a team at Epic are really wrestling with at the moment. And I think that needs to be the direction the field is going. And I'd be fascinated to hear what your audience members think. Where do we need to be going? But also, what are families and service users that are receiving care? What do they think? And the hope is to be doing some qualitative work to really start digging into that in some real depth going forwards. With regards to some of the possibilities, I think a key thing is about supporting more culturally responsive practices. And I think a key limitation of the FEPS assessment is it has a very comprehensive look at all the components of care. We are not currently assessing the degree to which programs are adopting culturally responsive practices and adopting cultural humility in care delivery. This is something that we've been talking to our DEIA team about at quite some length. And the hope is to be much more actively incorporating that going forwards. The idea being then that we can more proactively support programs in areas they are struggling in this space. The hope then being we'll start to see more equitable outcomes going forwards. Another area that a colleague of mine, Dr. Klima Bolden-Thompson in particular, has really been focusing on is much more greater expertise and focus in trauma care. So we do see individuals from historically marginalized group and Black and African males in particular reporting disproportionate amounts of trauma when they're coming into these services, and how that can add a lot more complexity and need in terms of care. They've been piloting a trauma integrated approach to CSC, and I think critically they found it to be something that is feasible and appropriate for this setting. And the hope is that more work here can happen to really support a more trauma integrated approach that may address a broader cross section of the needs of the people that are being served. Another thing is, I think, greater service flexibility and service engagement. Through COVID-19, we've seen a major transition from in-clinic services to remote delivery. And I think that has the potential to really support engagement in some of these programs, and particularly more rural and remote communities where there may not be services locally, so may need very long distances or some very hard choices that are made about how they can actually support engagement in these type of care. As we are transitioning more towards remote care and early psychosis, this may be something we can use to support sort of more remote or isolated communities. Another thing is greater lived experience involvement. So as I mentioned, that is something that we recognize to be a central component of what the model is in TTA. Critically, peer specialists were not something that was closed in the RAISE study, so the study that Bennett and Rosa had used in that data. So the hope is, as we are transitioning more towards incorporating lived experience and family involvement, we may be addressing some of the disparities we're seeing already. And then I think the last thing to really highlight is so some of the broader, bigger political questions that we might have around how we support individuals with mental illness. And there's been an increasing focus on sort of the intersection of poverty and support that we see in our systems, and how that can really perpetuate and exacerbate both inequities we see in experiences, but also could be huge barriers to care. An example for that being how if someone is homeless, then what do we expect the challenges and the issues they're dealing with on a day-to-day basis may be so much larger and more extensive than anything could be supported by an early psychosis program alone. And there are really interesting models, for example, in Quebec, where they're trialing coordinated specialty care with housing to see if that can then support individuals who have sort of unsheltered housing challenges, seeing if that can then help a large proportion of the individuals being served. Okay, and as I mentioned, I think for us going forwards, a huge way to start addressing that is, again, speaking to our service users, our family members, our providers, to really understand people's wants and wellness journeys. Okay, so I'm aware of the time. I only have 3 minutes. So I just wanted to lastly sort of mention this by saying a huge thank you to the huge team that's involved in this project, not least Dr. Tara Needham, Dr. Rachel Lowy, Kate Hardy, who lead our UC Davis, UCSF, and Stanford teams respectively. Thank you so much for your time.
That was fantastic. I'm going to coordinate with Alicia here. She'll get questions from folks in the room, and I will look at questions that are online. We have a question in the room. We're going to use the mic so everyone can hear it. But I do want to say, Mark, that was a fantastic talk. I've heard part of it before, and I continue to learn more and more from the work that you're doing. And I will save my questions because I have more access to you than the rest of the folks here. So go ahead.
Thanks very much for your talk, and super impressed with the ambition and the scope of what you're trying to do. Very, very impressive. Certainly your emphasis on fidelity is hugely important, but one thing I didn't hear as much about was actually the description of patient outcomes, other than your mention about hospitalization rates within the first year of care. Aren't those patient level outcomes in some ways the most important features of success or lack thereof for your programs? That's one question. And then secondly,
Jim, I'm going to ask you to pause there because we have about 30 seconds. So let Mark answer that first question.
Thanks very much.
Yeah, I would say yes, I would absolutely agree. And a big part of that is why we have the Learning Healthcare Network, where we are supporting the harmonization of data collection. And so we can see how individuals are progressing over time. So that is a big part of the model, and also seeing how individuals are improving and perhaps not improving. And as we're getting more data on an individual program level, we can start to incorporate that into our fidelity assessments too. And that also links to another thing, I think, which will be a longer term ambition, is to start linking that outcomes to fidelity data as well. So yes, I think individual service user level outcomes in addition to program models, I think that's very much the direction we're going, and agree is a huge part of what we should be looking at when we're thinking about, is a program doing well.
Thanks for that. And it is 1 o'clock already.
Oh,
dang it. We'll have to just bring you back. That's what we'll just have to do. So I appreciate everyone's time. This has been an exceptional talk, and really appreciate it. And I also wanted to say that the way that you presented, it made us feel like we were right at home with you. It was so personable, even though you were remote. So I really appreciate the way your delivery. So thank you for that, for making it as attuned and responsive as you made it. So thank you. And I will see you on Tuesday. Bye.
Thank you so
Bye,
much.
everyone.
Bye, everyone.